Welcome to the Funnel Effect. We are diving deep today into, well, really a revolutionary shift in how we understand heart disease.
Mhm.
We've been handed a truly dense yet indispensable source. Excerpts from Cardiac Magnetic Resonance in the Evaluation and Management of Nonischemic Cardiomyopathies, written by Nisha Hosadurg, Patricia Rodriguez-Lozano, Amit R. Patel, and Christopher M. Kramer.
Quite a lineup.
Indeed. And this review, it confirms that cardiac imaging has moved way beyond just, geometry and function. It's stepped firmly into the realm of molecular biology and tissue structure.
That's really the core of our deep dive today. Our mission, if you will, is to clearly define why cardiac magnetic resonance, or CMR, is now considered the gold standard tool in looking at non-ischemic cardiomyopathies, these NICMs.
Right.
For decades, a diagnosis of heart failure often just stopped at dilated or thickened. That was kind of it.
Yeah, the description.
Exactly. This source shows that CMR provides that critical missing link, the specific reason why, based on tissue characterization.
So we're not just confirming that the heart muscle is struggling anymore. We're actually differentiating why it's struggling. Is it a genetic mutation, or maybe iron buildup, or is it active inflammation, that kind of thing?
Precisely. We're moving toward a much more personalized approach. CMR lets us actually see the microscopic damage, the fibrosis, the iron, the inflammation, the edema.
Wow.
And that information then dictates, okay, does this patient need an ICD? Do they need aggressive chelation therapy? Or maybe anti-inflammatory drugs? We'll be distilling how CMR's multi-layered insight really guides these crucial, sometimes life-changing treatment plans.
I think the most important takeaway for you, the listener, is just the sheer power of this technology. CMR is the reference standard for quantifying size and function. Yes, we know that.
The gold standard there.
But its unique value, the real game changer, is this tissue characterization. It feels like it sees the invisible. Okay, so let's unpack this, starting with the fundamental techniques, the actual toolkit that gives CMR this unique power. Okay, let's start with the foundational data then. The source confirms CMR is the gold standard for accurately quantifying those essential cardiac metrics. Chamber dimensions, ventricular function, ejection fraction, that sort of thing, and overall cardiac mass.
Right.
Why is that accurate quantification so critical in NICM specifically?
Well, because NICMs, pretty much by definition, they present with myocardial dysfunction or dilation. So to accurately track if the disease is progressing or maybe how well a therapy is working, you absolutely need reproducible, accurate baseline measurements.
Makes sense.
And CMR really excels here. It gives you highly accurate volume and mass measurements, and it's free from the geometric assumptions that other methods sometimes have to make.
Right, like echo.
Exactly. But as we established, the real utility where it gets really interesting lies in what we call tissue characterization.
And this tissue characterization isn't just like a pretty picture, is it? We're talking about techniques that are validated against actual biopsies, against histopathology.
Absolutely. We're looking at essentially 4 primary quantitative techniques, and these translate the MRI signal into objective markers of disease. These markers have been shown to correlate directly with what a pathologist actually sees when they slice and stain the heart tissue.
Well, let's dig into those. Let's start with the first one, the one that uses contrast. Late gadolinium enhancement, or LGE.
Right, LGE. This is really the cornerstone for assessing what we call replacement fibrosis, basically, established focal scar tissue.
Okay.
So the contrast agent, gadolinium, is injected, and then you wait a bit, let it distribute. Healthy heart muscle, it doesn't really hold on to the contrast because the cell membranes are intact.
Right.
But where those heart muscle cells, the myocytes, have died and been replaced by fibrous scar tissue, that leaves a bigger space between the remaining cells, the extracellular space, and that space holds on to the contrast. So the area lights up, it looks bright white on the delayed images.
And what's crucial here isn't just that it lights up, but the pattern of that lighting up, right?
Exactly. The location and the pattern of the LGE are often, well, almost pathognomonic, meaning they point very strongly to a specific diagnosis.
How so?
Well, for example, scar caused by a heart attack, ischemic disease that typically follows the path of a coronary artery blood supply. It usually starts just under the inner lining, the subendocardium.
Okay.
Scar in these NICMs, however, shows up in non-coronary patterns. It might be in the middle of the wall, mid-wall, or near the outer surface subecardial. That pattern difference alone instantly helps us narrow down the potential underlying cause.
Okay, so LGE is great for seeing that focal established scar, but what about scarring that's maybe more diffuse, spread out through the entire muscle? Or things like swelling and inflammation? That's where this parametric mapping comes in.
That's exactly where the power of quantitative mapping truly emerges. LGE, it can miss that crucial diffuse process. Parametric matting gives us actual numbers, T1, T2, and T2 relaxation times, which are highly sensitive to these microscopic changes in tissue composition.
All right, let's drill down on T1 mapping first. What's it measuring even before you give any contrast?
So native T1 mapping measures the longitudinal relaxation time of protons in the tissue. In maybe simpler terms, it's sensitive to the chemical environment the water molecules are sitting in.
Yeah.
When that environment changes, maybe because there's fibrosis or edema or some kind of storage molecule accumulating, the T1 time changes. A low native T1 suggests something's accumulating inside the cells, like lipids or sphingolipids, which we see in Anderson-Fabry disease.
Huh.
Conversely, a high native T1 suggests an expansion of the space outside the cells, the extracellular space. And that's the key finding in diffuse interstitial fibrosis or in infiltrative diseases like amyloidosis.
And T1 then leads us to this thing called extracellular volume fraction, or ECV, which, reading the source, feels like maybe the most powerful prognostic marker you mentioned.
ECV is, it's incredibly powerful. It's derived by comparing those T1 measurements before and after you give contrast, and you also factor in the patient's hematocrit, their red blood cell count.
Okay.
It literally calculates the percentage of the heart muscle volume that is not made up of heart muscle cells. So if the heart muscle is, say, 25% non-myocyte material, the ECV is 25%.
Got it.
And this volume, this non-myocyte space, that's where the diffuse fibrosis lives. The source repeatedly emphasizes that ECV is highly prognostic in, well, nearly all NICMs. It gives a measurable numerical marker of the disease burden, even if the scar isn't big or dense enough to show up clearly on LGE.
Wow. Okay, so if T1 and ECV track more chronic scarring processes, T2 mapping sounds like it tracks more the acute stuff, the hot phases of disease.
That's the key distinction, exactly. T2 mapping tracks the transverse relaxation time, which is dramatically influenced by water content. So an elevated T2 signal basically means myocardial edema swelling.
Water content, okay.
And that swelling signifies inflammation. If T2 is elevated, we know the patient is likely in an active or hot phase of their disease. And that often warrants a completely different therapeutic approach, usually involving anti-inflammatory drugs compared to just managing chronic scarring.
And the final piece of this unique toolkit is T2 star. T2, what's that one for?
T2 is highly specialized. It measures the relaxation time that's specifically affected by local magnetic field distortion. Why? Because iron, specifically the storage form called hemosiderin, creates these dramatic magnetic field inhomogeneities. Therefore, T2 provides a highly accurate quantitative measure of myocardial iron overload, or MIO. Clinically, it's often called cardiac siderosis, and we'll definitely delve into why the specificity of this tool is, frankly, a massive lifesaver later on.
It's really incredible how these specific tools allow us to classify NICM so accurately. Okay, so we'll now proceed through the source material, looking at how we use these LGE patterns and mapping thresholds to identify NICMs. The source categorizes them into genetic, infiltrative, dilated, and inflammatory diseases, and also catching them before they cause overt, irreversible symptoms. Right, let's start with the genetic cardiomyopathies then, beginning with probably the best-known one, hypertrophic cardiomyopathy, or HCM, #2A. Hypertrophic cardiomyopathy, HCM.
HCM is actually pretty common, affecting roughly 1 in 200 to 1 in 500 people. It's defined by unexplained myocardial hypertrophy, basically, thickening of the heart muscle without an obvious cause like high blood pressure or valve disease.
Right.
Traditionally, diagnosis relied on measuring the thickest part of the wall, the maximal wall thickness. The cutoff was usually 15 millimeters or more, or maybe 13 millimeters if there was a known family history or specific genetic mutation found.
But the source suggests that just relying on those fixed numbers, those metrics, is a bit problematic, doesn't it?
It really is, because those thresholds often came from older, smaller studies, and they don't adequately account for demographic factors. Things like age, sex, body size, they all influence normal heart thickness.
Sure.
A highly trained athlete might have a thick wall that's perfectly normal for them. So the source notes that shifting towards demographic-adjusted approaches is really vital for improving diagnostic accuracy and avoiding, over- or underdiagnosis.
Okay, so this brings us to the CMR advantage. How does it actually improve the diagnosis beyond what, say, an echo can provide?
Primarily through its superior spatial resolution and its comprehensive coverage of the entire heart. CMR accurately measures wall thickness across the whole ventricle, not just the parts easily seen by echo.
And why is that so important?
Well, it's crucial because HCM doesn't always affect the septum, which is the easiest part to see on echo. Sometimes it presents as focal hypertrophy, maybe just at the very tip, the apex, or on the posterior walls. These are areas notoriously difficult to visualize and measure accurately with standard echo.
So are you saying CMR actually catches cases that echo might miss?
Substantially, yeah. The source cites data showing that CMR helped reclassify approximately 20%. 1 in 5 patients referred to expert centers with presumed or suspected HCM.
Wow, 20%. That's significant.
It's a massive reduction in diagnostic uncertainty. 1 in 5 patients received a revised or confirmed diagnosis based purely on the superior imaging from CMR.
Okay, let's move to the scar pattern then,
Yeah.
the LGE signature in HCM. What does that typically look like?
The characteristic pattern is patchy. It's non-ischemic, meaning it doesn't follow a blood vessel distribution, and it's typically in the mid-wall, the middle layer of the heart muscle.
Oh.
It's most frequently seen right at the points where the right ventricle connects to the RV septal insertion sites. And this LGE presence is pretty widespread. It's found in over 50% of HCM patients.
Okay, so more than half have some scar. The critical discussion then becomes about prognosis, right?
Yeah.
Specifically, the risk of sudden cardiac death, or SCD. It sounds like just having LGE isn't enough. It's about the amount of scar, the burden.
That's exactly where the numbers become actionable. The LGE burden, basically the percentage of the total LV mass that is scarred, is strongly associated with SCD risk. The current clinical consensus, reflected in some guidelines, uses an LGE burden of 15% or more as a Class 2B indication for considering an implantable cardioverter defibrillator, ICD, for primary prevention.
Because it signifies a doubling of SCD risk, roughly.
That's the data, yes, a doubling of risk. But wait, the source also points out some conflicting data here. You have a guideline threshold of 15%, but then a detailed meta-analysis suggests maybe a 10% LGE threshold was actually most accurate for predicting SCD. Why is there this gap between, robust research and the official clinical guideline? Is the evidence for 10% just not strong enough yet, or are clinicians maybe being a bit overly conservative?
That's an excellent and really critical question. That gap often exists because guideline development has to balance sensitivity with specificity, and they tend, understandably, towards conservatism. Okay.
The 15% threshold is very specific. If you have that much scar, you are definitely at high risk. But using 10% as a cutoff, as the research suggests, would be more sensitive. It would catch more potentially at-risk individuals who might otherwise be missed by the higher threshold.
Right, catch them earlier.
Exactly. This field is constantly evolving, though. As more data accumulates, we fully expect those thresholds might shift towards greater sensitivity, prioritizing earlier intervention for more people.
And the advanced mapping techniques, T1 and ECV, they also provide prognostic data, maybe even earlier than LGE shows up.
Absolutely. Elevated native T1 and ECV, they signal that diffuse interstitial fibrosis we talked about, and here's where it gets really subtle. ECV, that extracellular volume, can be increased even in patients who have the HCM gene mutation, but haven't actually developed the physical thickening, the LVH, yet.
Wow. So the scar is starting before the muscle thickens.
Think about that, yeah. The genetic trigger is causing microscopic scarring before the heart muscle has even noticeably thickened. This makes ECV potentially a really powerful pre-symptomatic marker. It could allow researchers to track disease progression much earlier and maybe even monitor if a future gene therapy is actually working at the tissue level long before structural changes occur.
That's incredible.
We also should note that elevated T2, indicating that edema or active inflammation, is also associated with a worse prognosis and life-threatening arrhythmias in HCM, sometimes even more strongly than LGE alone.
Finally, the source mentions the complexity of HCM, noting this NIH registry identified 6 distinct morphological subtypes. That almost moves HCM from being one single disease to more like a collection of related syndromes, doesn't it?
That's the key realization, exactly. HCM is very heterogeneous. The subtypes range from affecting just the apex to causing obstruction in the middle of the cavity and so on. And analyzing the genetic status against the morphology offers profound insight.
How so?
Well, genotype-positive patients, those with a known mutation, are more likely to have specific patterns like a reverse curve to their septum and more LGE, whereas genotype-negative patients often show just isolated thickening at the base of the septum with less LGE. This kind of morphological and genetic specificity is absolutely key to better predicting future risk for individual patients. Hashtag 2B, arrhythmogenic cardiomyopathies, ACM.
Okay, moving on to arrhythmogenic cardiomyopathy, ACM. This is another one where the definition seems to have evolved quite a bit thanks to CMR. It used to be focused only on the right ventricle rate, ARVC.
Correct. We used to call it ARVC, arrhythmogenic right ventricular cardiomyopathy. The underlying issue is often mutations in desmosome genes. These are proteins that kind of hold heart cells together. This causes fibrofatty replacement, basically scar and fat replacing muscle tissue, which was first observed most prominently in the RV.
But CMR changed that view.
Yes, CMR has clearly demonstrated that the disease frequently affects the left ventricle, the LV, or sometimes both ventricles simultaneously, hence the broader term ACM, arrhythmogenic cardiomyopathy.
So what are the telltale signs of RV involvement on CMR then?
We look for a few things. RV systolic dysfunction, the RV isn't squeezing well. Dilation, the RV is enlarged. And regional wall motion abnormalities, parts of the wall might be akinetic, meaning not moving at all, or dyskinetic, bulging outwards paradoxically when the rest contracts.
Right.
Qualitatively, clinicians sometimes look for something called the accordion sign. Imagine the thin wall of the RV kind of crinkling up and down with each beat. It suggests focal dysynchrony, especially near the tricuspid valve. It can be a very specific, though sometimes subtle, marker of early disease.
I remember the source mentioning a shift in the diagnostic criteria, particularly around RV size. Why did those older fixed cutoffs for RV size become unreliable?
Yeah, that's partly because older CMR imaging techniques, the SEN sequences, sometimes distorted the image slightly or weren't perfectly consistent across different senders and machines. And the RV geometry itself is really complex. It's not a neat bullet shape like the LV.
True.
Recognizing this, the 2020 Padua criteria moved away from fixed numeric cutoffs. They now recommend using test-specific nomograms for RV size and function. Basically, you compare the patient's measurements to standardized data from healthy populations imaged using the same technique. So the diagnosis of RV dilation or dysfunction is now relative, not absolute.
That makes more sense. Okay, let's discuss the critical LGE pattern for ACM.
Yeah.
What does the scar look like here?
Right. In classic ARVC, the primary RV form, we look for LGE in the RV free wall. That's considered a major diagnostic criterion. However, it can be tricky to image reliably because that wall is naturally very thin.
Okay.
In the left dominant or biventricular variant, sometimes called ALVC or just biventricular ACM, the LGE pattern is often quite pathognomonic. You see this ring-like pattern of enhancement. It's usually subepicardial, near the outer surface, or mid-myocardial, and involves 3 or more segments.
Ring-like.
Yeah, and importantly, the fibrofatty replacement process in ACM typically starts from the outside, the epicardial layer, and progresses inward towards the endocardium. That LGE pattern reflects this process.
And what does finding LGE mean for prognosis in these ACM patients?
The presence of LGE, especially that distinctive ring-like pattern if the LV is involved, is an independent predictor of sustained ventricular arrhythmias and a significantly increased risk of SCD. So again, CMR provides really actionable prognostic data that helps guide decisions about things like ICD implantation.
You mentioned earlier a potential diagnostic challenge. The hot phase of ACM sometimes mimicking myocarditis. Can you elaborate on that little nuance?
Yes, that's an important point. ACM is fundamentally a genetic condition, but it seems it can be exacerbated by things like intense exercise or maybe even inflammation. During an active phase, or a hot phase as it's sometimes called, you can actually see T2 elevation on CMR indicating edema or swelling.
Just like in myocarditis.
Exactly. It looks like acute inflammation, which is the hallmark of myocarditis. Clinically, it might present very similarly, but the underlying pathology is still that genetic desmosomal defect. It requires really careful clinical correlation, looking at the whole picture, and often genetic testing to confirm the underlying ACM diagnosis.
Because misdiagnosing it simply as myocarditis could be dangerous?
It could mean missing the long-term arrhythmia risk associated with the underlying genetic condition, which needs different management and surveillance.
Okay, now let's switch gears a bit to the infiltrative cardiomyopathies. Here, the goal seems to be identifying what specific material is actually depositing in the heart muscle. We'll start with cardiac amyloidosis, or CA, a disease caused by this extracellular protein deposition. #3A, cardiac amyloidosis, CA.
Right. Cardiac amyloidosis, whether it's the AL type from light chains or the ATTR type from transthyretin, is characterized by the accumulation of these misfolded protein fibrils in the space outside the heart cells.
Okay.
And CMR is really crucial here because the morphofunctional features it shows are highly suggestive. You typically see global thickening, not just the LV, but also the RV, and often the atrial walls are thickened. You see enlargement of both atria, biatrial enlargement, and often the ejection fraction, the pumping function, can be relatively preserved, especially early on.
That seems counterintuitive, the thick heart pumping. Okay.
It does, but the thickening isn't healthy muscle, it's stiff protein. When strain analysis is performed looking at the deformation of the muscle, the characteristic finding is often apical sparing. This means the base and the midsections of the LV wall don't deform well, they're impaired, but the very tip, the apex, seems relatively spared.
Interesting pattern. And the LGE, the scar pattern, reflects that protein infiltration too.
It absolutely does. The typical LGE in amyloid is diffuse and circumferential. It often spreads across the entire subendocardium, just under the inner lining, or sometimes it goes all the way through the wall, transmurally. And importantly, it often involves the atrial walls as well, which is a really strong clue for amyloid.
Okay.
In earlier stages, you might just see some patchy mid-wall LGE, but the classic progression is usually towards that diffuse, widespread pattern.
Now, for what sounds like the classic CMR hallmark of CA, these abnormal gadolinium kinetics, can you walk us through what happens to the contrast agent in this specific disease? It sounds quite unique.
It really is. It's probably the most fascinating biophysical signature on this list. So normally when doing LG imaging, the MRI technologist carefully calculates something called an inversion time. The goal is to perfectly time the image acquisition so that the signal from the blood inside the heart chambers is nulled or suppressed, made black. This makes the heart muscle stand out clearly.
Right, standard procedure.
In healthy tissue, the blood pool nulls first, and then a bit later, the normal myocardium nulls. In amyloidosis, however, that entire interstitial space, which is massively expanded because of all the amyloid protein packed in there, acts like a giant sponge. It just sucks the gadolinium contrast out of the bloodstream almost instantly.
So if the contrast leaves the blood really fast and rushes into the heart tissue, what happens to the nulling point?
The concentration of gadolinium in the myocardium becomes very high very quickly, while the concentration back in the blood drops rapidly. Consequently, the blood pool often nulls, turns black at the same time as myocardium, or sometimes even after the myocardium nulls.
The opposite of normal.
Exactly the opposite of normal kinetics. This reversal is highly diagnostic and a major red flag for CA. If the technologist struggles to null the blood before the muscle, they're immediately thinking amyloid.
Wow. And the quantitative mapping, T1 and ECV, presumably confirms this massive extracellular deposition.
Oh, absolutely. Native T1 values are markedly elevated, and ECV is usually dramatically increased. We're often talking about ECV values well above 40%, sometimes even 50% or 60% in advanced cases. That means half or more of the heart muscle volume isn't actually contracting muscle, it's non-contractile protein.
That's staggering.
And as you might expect, that ECV number is incredibly prognostic. A meta-analysis mentioned in the source found ECV to be the most powerful prognostic marker in CA, associated with a massive hazard ratio of 4.27 for adverse events.
And this numerical data, the ECV, is also what allows clinicians to actually monitor how well treatments are working, right?
That is perhaps the most crucial clinical application right now. Of course, serial ECV measurements can track the disease progression, or hopefully regression, in response to these newer anti-amyloid therapies.
Okay.
The source highlights studies showing that in patients with ALCA, a reduction in ECV of 5% or more at 2 years predicts significantly better survival. Similarly, in ATTR-CL, treatments like tafamidis and patisiran have been shown using serial CMR with ECV to delay or reduce the progression of myocardial amyloid deposition. It provides objective proof the drugs are working in the heart tissue itself.
We should probably clarify the diagnostic pathway here, though. CMR sounds highly sensitive for suggesting CA. The source says 86% sensitivity, 97% specificity, which is great. But it doesn't actually tell you which type of amyloid it is, AL or ATTR, does it?
Precisely. That's a key point. CMR is the essential screening and staging tool. It tells you, with high confidence, yes, there appears to be significant cardiac amyloidosis here, and here's how extensive it is. But to determine if it's the light chain type, ALCA, which often needs chemotherapy, or the transthyretin type, ATTR-CA, which has specific therapies now, we rely on complementary tools, like blood and urine tests for light chains, and crucially, bone scintigraphy, which is a type of nuclear medicine scan. Bone scintigraphy turns out to be highly specific for ATTR-CA, with sensitivities often reported up to 97%. So they work together. CMR finds the amyloid and assesses its impact. Scintigraphy often helps nail down the specific protein subtype, guiding the specific treatment path. #3B. Myocardial iron overload. MIO.
Okay, let's switch now to a different kind of storage disease, one that represents a really acute threat. myocardial iron overload, or MIO, often called cardiac siderosis. This is one where early detection isn't just helpful, it sounds like it's absolutely mandatory.
It truly is. MIO, most commonly seen in patients who need multiple blood transfusions for conditions like thalassemia major or sickle cell disease, causes a toxic cardiomyopathy leading to heart failure. Historically, it was a leading cause of death in these populations.
But the key is reversibility.
Exactly. The cardiomyopathy caused by iron is entirely reversible if you start iron chelation therapy drugs that remove excess iron from the body early enough. But if you miss that window, the damage becomes permanent and often fatal.
And the detection relies almost exclusively on that specialized T2 mapping technique we mentioned earlier.
T2 mapping is really the star here. It's tailor-made for this problem. As we said, iron deposition creates these powerful local magnetic fields within the heart muscle. These fields act like microscopic brakes on the MRI signal, causing it to decay much faster. This leads to a dramatically shortened T2 relaxation time.
So the shorter the T2 time,
the more iron is present. It's a direct quantitative relationship.
Okay, so what are the critical cutoffs, the numbers that trigger clinical action?
The key number is 20 milliseconds. A T2 value less than 20 meters is considered diagnostic of significant myocardial iron overload and mandates the initiation or intensification of iron chelation therapy.
And there's an even more severe category.
Yes. T2 less than 10 milliseconds. This level is considered severe MIO, and it's associated with a significantly greater risk, something like a 50% chance of developing heart failure or serious arrhythmias within just 1 year in patients with thalassemia major.
Within 1 year? That's not a distant chronic risk. That sounds like an imminent acute threat.
It absolutely is. Finding a T2 below 10 meters is a cardiac emergency requiring immediate and aggressive chelation.
The source provides a really stunning example of the clinical impact this single measurement tool has had, doesn't it?
It's honestly one of the most compelling examples in all of medical imaging of how a non-invasive biomarker directly impacted public health outcomes. Following the widespread introduction of T2 imaging for monitoring iron overload in the UK, starting around 1999, survival in patients with thalassemia major improved dramatically. The data showed a 71% reduction in cardiac deaths over the subsequent 5 years or so. This single, non-invasive measurement prevented deaths that were previously almost considered an inevitable consequence of chronic transfusions. It provided that precise, early warning, allowing chelation to start before irreversible heart damage occurred.
Just incredible. Does native T1 mapping play any complementary role here? Given its role in other storage diseases, could it help too?
It seems it might, although T2 really remains the established standard for quantifying clinically significant iron. Studies have shown that low native T1 values also correlate with myocardial iron overload.
Why low T1 here?
The theory is that T1 mapping might be more sensitive to iron stored within the ferritin molecule, which is thought to be an earlier stage of iron accumulation, perhaps less magnetically active than the later stage, hemosiderin. T2 primarily measures the hemosiderin iron. So potentially, combining T1 and T2 might improve our sensitivity for detecting milder MIO even earlier, but T2 is still the one that drives the major clinical decisions based on those validated thresholds. #3C, other storage diseases, AFD, and Danon disease.
Okay, let's briefly touch on two other, perhaps rarer storage diseases mentioned in the source, starting with Anderson-Fabry disease, AFD. This one also seems to have a unique CMR signature.
It does. AFD is an X-linked lysosomal storage disorder. It leads to LV hypertrophy, a thick heart muscle, and eventually fibrosis, but it's caused by the intracellular accumulation of a specific type of lipid called globotriaosylceramide, or GB3, within the heart muscle cells themselves.
So storage inside the cells, not outside like amyloid.
Exactly. And its unique early marker on CMR is a low native T1 time. This is considered pathognomonic for Fabry disease in the context of LVH. Because unlike amyloidosis, where protein expands the outside of the cell, raising T1, in Fabry disease, these single lipids accumulate inside the cells, and this intracellular storage environment actually shortens the T1 relaxation time.
So low T1 is the flag.
Low T1, often before there's even significant hypertrophy or any scar visible on LGE, it's a very early sign.
So it sounds like we can essentially stage AFD using CMR based on these findings.
Precisely. The source suggests a potential staging system based on CMR findings. Stage 1 might be the subclinical phase, characterized only by that low T1 signal.
Right.
Stage 2 involves the development of hypertrophy, often accompanied by midmyocardial LGE, which characteristically tends to occur in the basal inferolateral segment, the bottom side wall. You might also see T2 elevation in this stage if there's active inflammation.
And stage 3?
Stage 3 represents more advanced disease, with progressive LGE sometimes leading to myocardial thinning and irreversible damage. As you expect, the presence of LVH, and especially LGE, are strongly associated with increased risk of adverse cardiac events like arrhythmias and heart failure. This really underscores the potential value of detecting the disease much earlier via that low T1 signal.
And finally, a quick mention of Danon disease, which the source calls an HCM mimic. What distinguishing features does CMR offer here?
Right. Danon disease is another rare X-linked storage disease. It causes a very aggressive, often early-onset heart failure and mimics HCM by causing significant LV hypertrophy. On CMR, you see concentric or asymmetric LVH, often with really extensive LGE1 series, reported a median LGE burden of 35% of the LV mass, which is huge.
About 45%.
But the critical distinguishing characteristic from typical HCM seems to be the location of the LGE. Despite the overall septal hypertrophy, Danon disease often shows a characteristic sparing of LGE in the basal mid portion of the septum.
Yeah.
This specific location-based difference can help differentiate it from classic HCM patterns.
All right, let's move now into dilated cardiomyopathy, or DCM. This seems like a major challenge just because it has so many varied causes: genetic, viral, toxins, sometimes idiopathic. CMR is obviously vital here for confirming the diagnosis, but perhaps even more so for risk stratification, right? Hashtag 4A. Dilated cardiomyopathy, DCM.
Absolutely. DCM, defined by that LV dilation and systolic dysfunction, is surprisingly common. Prevalence estimates are around 1 in 250 individuals. CMR confirms the diagnosis by providing those highly accurate and reproducible estimates of volumes, mass, and function.
Okay.
And the tissue characterization profile often shows a mix of disease processes going on. You can have diffuse interstitial fibrosis, which we quantify with T1 and ECV, and you can also have focal replacement fibrosis, which we see as LGE.
So what's the signature LGE pattern here? The one that immediately suggests a non-ischemic cause, distinguishing DCM from, say, scar after a heart attack?
The key pattern to look for is patchy, or sometimes linear, longitudinal striae of mid-wall LGE, most commonly located along the septum, the wall between the ventricles.
Mid-wall septum, got it.
That location is paramount. Mid-wall, non-vascular distribution basically screams non-ischemic. This pattern is found in about 30% or so of patients diagnosed with DCM and immediately points away from coronary artery disease towards other causes, often genetic or idiopathic.
And finding this mid-wall scar, this LGE, is independently prognostic. It leads to actionable decisions.
Yes, very much so. The presence of mid-wall fibrosis on LGE is powerfully prognostic. It's independently associated with increased risk of all-cause mortality and sudden cardiac death. Furthermore, having a higher LGE burden, more scar, predicts that patients are less likely to benefit from standard guideline-directed heart failure therapies. They have a lower probability of seeing improvement in their heart function, what we call reverse remodeling.
Okay, I want to challenge the standard guidelines here a bit, based on what you're saying. If the primary cutoff for considering an ICD for preventing SCD is typically an LVEF ejection fraction of 35% or less.
Correct, that's the main trigger.
But LGE provides such powerful independent prognostic data about SCD risk. Shouldn't the presence of LGE, especially maybe significant LGE, potentially override that LVEF threshold, or at least strongly modify it?
That is precisely the conversation happening in the field and what the source material strongly argues for. LGE fundamentally improves risk stratification beyond just LVEF alone. The presence of mid-wall LGE, even in DCM patients who have an LVEF above 35%, maybe 40%, or even higher, still suggests an increased SCD risk that would likely be missed if you only focused on the ejection fraction number.
So it finds a hidden risk group.
Exactly. Studies show the combination of LVEF and LGE provides significantly better predictive power compared to relying solely on that 35% LVEF cutoff. CMR helps us identify a higher risk group that current standard care often fails to capture adequately.
And it also appears that the T1 and ECV data, the markers of diffuse fibrosis, are still powerful predictors, even if there's no visible LGE scar.
Correct. Many DCM patients have significant diffuse interstitial fibrosis that just hasn't consolidated enough to form visually obvious focal LGE. T1 mapping and ECV quantify this diffuse scarring, and that data remains independently prognostic of adverse outcomes, even in the absence of LGE. The ultimate risk stratification probably requires integrating all three: LVEF, LGE presence and burden, and the quantitative mapping data like T1 and ECV, hashtag 4B. cardiac sarcoidosis, CS, and autoimmune diseases.
Okay, let's talk about cardiac sarcoidosis, CS. This involves inflammatory granulomas forming in the heart, but diagnosis is notoriously challenging because the granulomas are patchy. Why does this patchy nature make the traditional approach, endomyocardial biopsy, so unreliable? And why does CMR overcome that limitation?
Yeah, endomyocardial biopsy, where they take tiny samples of heart tissue, is often limited in sarcoidosis precisely because the disease involvement is so patchy. You might biopsy 5 spots and completely miss the areas affected by granulomas, leading to a false negative result. The reported diagnostic yield is actually quite low.
So a lot of misdiagnoses.
Potentially, yes. CMR overcomes this limitation because it surveys the entire heart muscle in 3 dimensions. It can identify even small areas of inflammation, edema, or scar resulting from those granulomas, regardless of where they are, with high spatial resolution. This results in a much higher diagnostic yield. The source notes typical sensitivity around 95% and specificity around 85% for CMR in diagnosing CS.
That's a huge difference. So what are the hallmark LGE patterns we look for in CS?
The patterns seen on LGE often reflect where the granulomas tend to deposit. So you frequently see LGE in the LV subpicardium, near the outer surface, or multifocal patchy LGE throughout the LV wall, often involving the septum, and importantly, involvement of the RV free wall is also common. These patterns are found in over 90% of autopsy or transplant-confirmed cases.
Okay.
There's even a highly specific visual cue described in the literature called the hook and triangle sign. This involves a triangular area of LGE at the base of the infraseptum, extending into the adjacent inferior part of the RV wall. If you see that specific pattern, the specificity for CS is reported to be extremely high, like 98%.
Wow, the hook and triangle. Very specific. How does CMR help differentiate between chronic, burnt-out scar from old granulomas versus acute active disease that might warrant immediate treatment?
That's the T2 signal again, the marker for edema or inflammation. Elevated native T2 values suggest active inflammation, meaning the granulomas are currently hot and causing swelling. This is absolutely critical because active cardiac sarcoidosis requires anti-inflammatory therapy, usually high-dose steroids or other immunosuppressants, to prevent further damage.
So T2 guides therapy initiation.
It strongly suggests the need for it. While FDG-PE imaging, which looks at metabolic activity, remains the gold standard for assessing active inflammation in sarcoidosis, T2 mapping on CMR provides rapid complementary structural data on the resulting edema. And crucially, serial T2 measurements can potentially be used to monitor the effectiveness of anti-inflammatory treatment by showing a reduction in edema over time.
And what does finding LGE mean for prognosis in CS? Is it similar to other conditions?
Yes, LGE presence and burden are strongly associated with increased odds of mortality and ventricular arrhythmias in CS. The risk seems to escalate significantly if the LGE burden is greater than about 5% of the LV mass, which is a relatively low threshold compared to HCM, for instance, and this risk seems elevated regardless of the baseline LVEF. Furthermore, involvement of the right ventricle, which CMR detects much better than echo, generally portends a particularly worse prognosis.
And finally, let's just briefly mention the role of CMR in other autoimmune rheumatic diseases.
Right. CMR is becoming increasingly vital for detecting and monitoring cardiovascular involvement in systemic autoimmune conditions like systemic lupus erythematosus, SLE, and rheumatoid arthritis, RA, among others. We know these conditions carry increased cardiovascular risk. In cases of suspected myocarditis related to SLE, for example, elevated T1 and T2 values can help confirm myocardial inflammation and fibrosis, guiding therapeutic decisions. Importantly, studies have shown these T1 and T2 values often decrease after successful anti-inflammatory treatment, providing objective evidence that the therapy is actually working at the heart muscle level. CMR can even detect subclinical myocardial dysfunction, like impaired strain, in patients with these conditions even before they develop overt cardiac symptoms, highlighting its potential utility as a screening tool in these high-risk populations.
So we've clearly established that CMR is diagnostically and prognostically pretty unparalleled for NICMs. But for you, the listener, thinking about real-world application, the practical aspects, safety, workflow, accessibility are just as important. Let's touch on those. #tag practical challenges and safety.
Okay, yeah, good point. Let's discuss cardiac implantable electronic devices, or CIEEs, pacemakers, and defibrillators. Given the really profound prognostic data CMR provides, especially LGE, the best clinical practice is probably to try and obtain a CMR before a device needs to be implanted, if possible.
Get the data first.
Exactly, because once the device is in, even though most modern CIEDs are now MR conditional, meaning they're designed to be safe in the scanner under specific conditions, you still face logistic hurdles for subsequent scans. And there's always the potential for image artifacts from the device leads.
Right.
The workflow definitely becomes more complex. You often need a cardiac device specialist present during the scan to program the device into a safe MRI mode and then check it afterwards. However, the imaging technology itself is adapting. Techniques like using special wideband LGE pulse sequences are becoming pretty standard now to help mitigate the artifacts created by the device, improving image quality even after implantation.
Okay. And what about the safety concern that used to hang over gadolinium contrast use, particularly in patients with chronic kidney disease?
Yeah.
Has that been entirely resolved now?
That concern was very real historically, linked to a devastating condition called nephrogenic systemic fibrosis, or NSF. This was primarily associated with older, linear-type gadolinium contrast agents.
Right. I remember hearing about that.
But with the mandatory shift worldwide to using the newer, much more stable Group 2 macrocyclic agents, that risk of NSF has plummeted to exceedingly low levels, even in patients with severe kidney disease. The official consensus from bodies like the American College of Radiology is now quite clear. The immense diagnostic and prognostic value of gadolinium-enhanced CMR in conditions like NICMs far outweighs the negligible, almost theoretical risk of NSF with these modern agents.
So don't withhold it if needed.
They strongly recommend against withholding contrast when a gadolinium-enhanced CMR is clinically indicated based on risk-benefit assessment. And it's worth noting, too, that for follow-up scans, maybe just to assess interval changes in T1 or ECV for monitoring diffuse fibrosis, gadolinium can often be skipped entirely, further reducing any potential exposure.
Okay, that's reassuring. So if the diagnostic clarity is so high and safety is less of a concern with modern agents, is the cost-effectiveness and accessibility still a major hurdle for wider integration into routine practice?
That's still a factor, absolutely. CMR remains more expensive and less widely available than, say, echocardiography. Integrating it fully requires dedicated MRI scanners, specialized cardiac coils, software, and importantly, highly trained technologists and interpreting physicians. However, the argument for cost-effectiveness is often made by considering the downstream savings. An initial, accurate CMR diagnosis can potentially reduce the need for more costly invasive procedures later on, like maybe redundant biopsies, or possibly preventing inappropriate ICD placements based solely on LVEF criteria that might be refined by LGE data. The big goal now in the field is really focused on making the scans themselves faster and more efficient, to help integrate them more seamlessly into standard clinical workflows and improve accessibility.
Okay, that brings us neatly to the future developments mentioned in the source. They detail several exciting avenues aimed at reducing scan time and maybe even reducing the reliance on gadolinium contrast. Let's start with something called virtual native enhancement, or VNE. Sounds intriguing.
VNE is really fascinating. It basically harnesses the power of deep learning and artificial intelligence to try and sidestep the need for gadolinium altogether, at least for detecting scar.
How does it work?
It takes the data from the quantitative maps, like the native T1 maps we discussed, and combines it with information from the standard CT images that show heart motion. Then, sophisticated algorithms trained on vast data sets essentially learn to predict where LGE would have been if contrast had been given. It generates an image that looks remarkably similar to a conventional LGE scar map, but without ever injecting any contrast.
Wow. Does it work well?
Early studies, particularly looking at HCM, have shown really high agreement between VNE and conventional LGE for identifying the presence and location of scar. If VNE proves robust across all the different types of NICMs, it could potentially fundamentally change practice. It might eliminate contrast use in large screening populations or for routine follow-ups, significantly reducing scan time, cost, and any lingering safety concerns.
Very cool. And what about just cutting down the often lengthy time the patient has to spend inside the scanner? That's often a barrier, too.
Definitely. That's where techniques like all-in-one CMR and real-time CMR come into play. All-in-one CMR, sometimes called multi-parametric mapping or synthetic CMR, uses advanced sequences that simultaneously acquire data for multiple parameters, maybe T1, T2, and proton density all in one go.
Instead of separate scans for each.
Exactly. Instead of performing 6 or 7 separate sequences back-to-back, you might perform just 1 or 2 comprehensive acquisitions. From this raw data, you can then reconstruct multiple different image types and quantitative maps, significantly shortening the overall time the patient needs to be in the scanner.
And real-time CMR, what's the focus there? What are the trade-offs?
Real-time CMR focuses primarily on speed acceleration, often using techniques that allow imaging without the need for the patient to hold their breath, or even requiring strict ECG gating to freeze the heart motion. This is invaluable for patients who are very sick, perhaps breathless, or have highly irregular heart rhythms who just cannot cooperate with the demands of a traditional CMR scan.
But there must be a trade-off for that speed.
There usually is, yes. To achieve that real-time speed, you often have to sacrifice some degree of spatial resolution, the fine detail or temporal resolution, compared to a standard gated scan. So while you get dynamic information very quickly, the very fine detail needed for precise LGE pattern recognition or subtle wall motion assessment might be slightly compromised. Future developments are constantly working on reducing these necessary trade-offs, aiming for real-time imaging that maintains very high diagnostic quality across the board. #tag outro. So, just to synthesize the core message for you, the listener, from this deep dive, CMR really offers a revolutionary, multi-layered view into these non-ischemic cardiomyopathies. It moves the diagnosis way past just looking at simple structural failure, like size and pump function. It actually reveals the underlying cellular pathology, the fibrosis, the iron deposition, the inflammation, the edema.
Right, seeing the why.
Exactly. And this level of tissue specificity allows for a much more targeted etiologic diagnosis, figuring out the root cause, which is often simply unattainable with standard functional imaging alone.
And that highly specific data, whether it's the LGE burden percentage in HEM or that critical T2 threshold in cardiac siderosis, or maybe the change in ECV tracking amyloid treatment response, that data directly translates into really actionable clinical management decisions.
Absolutely. It helps guide crucial choices about device placement, dictates when to start critical therapies like chelation, and provides objective evidence of whether a chosen treatment is actually working at the tissue level.
It really does sound like the indispensable tool for personalized medicine in non-ischemic heart disease.
I think that's a fair assessment.
So given the remarkable prognostic power we've discussed, particularly from these quantitative CMR biomarkers like native T1 and ECV, especially their ability to identify subtle, diffuse interstitial fibrosis, that scarring that's often invisible even to LGE, here's the ultimate question, maybe for the future of cardiology. Should these advanced, often contrast-free mapping techniques become a standard, universally applied screening tool, particularly for populations known to be at risk for certain genetic or storage diseases? Could we potentially detect these conditions years before current guidelines suggest, thereby radically shifting our definition of early intervention? Something for you to mull over as you process all this data. Thank you for watching The Funnel Effect.